notre première table ronde assurer la prise en charge en santé mentale. La crise du Covid, de la Covid-19 a mis en lumière, vous savez, l'ampleur des besoins en santé mentale, alors aussi bien chez les populations que chez les professionnels de santé. En janvier 2021, les États membres de l'OMS ont souligné l'importance d'inclure la santé mentale dans les plans d'intervention et de préparation d'urgence de santé publique. Le Conseil exécutif de l'OMS a appelé les États à développer les services de santé mentale et de soutien psychosocial en favorisant un accès équitable
as we ensure fair access for remote healthcare. According to the World Health Organization, a lot of countries have adopted telemedicine or teletherapy for mental health and psychosocial support, self-support, e-learning, teleconsultations or AI for the spotting of disorders are more and more important. Now, in the roundtable, we'll be presenting a certain number of tools currently used in healthcare and their impact on populations and healthcare professionals. So please give a very warm welcome to Rabih El Chammay,
Anaid Atasuntseva.
Anaid Atasuntseva.
Venez nous rejoindre, Anaid. Lola Kola et Anushka Patel.
And Anushka Patel and Lola Kola.
Venez nous retrouver sur scène, s'il vous plaît. Alors, 30-35 minutes de discussion ensemble sur ce panel et ensuite on prendra vos questions dans la salle
and then we'll take the questions from the floor. I'd like to start with you, Rabih El Chammay. You are in charge of mental health at the ministry in Lebanon. You also teach at the St. Joseph University in Lebanon. You are stakeholder of an operation called Step by Step, which comes from the WHO and the mental health program in Lebanon through two randomized tests, trials that produce positive results for people suffering from depression and various disorders. And I think there's an app being set up in a certain number of countries, such as Thailand, I believe. Could you maybe tell us, first of all, more precisely what this is all about and the various steps of the implementation of this program? Well, yes, hello, Sophie, and thank you very much to the Pierre Fabre Foundation for this invitation. I'm delighted to be here for the very first time, and thank you very much to the teams for the support I've received. Maybe a few minutes to discuss this backdrop that Monsieur de Saint-Sarnin has set for us in terms of the context of humanitarian activities. It's true for many crises. In one entity, there may be one aspect more important than others, but as I listened to him, I thought that yes, in Lebanon, we are facing all these challenges, maybe a bit more. Nevertheless, things are doable. We cannot change the context, but things can be done in order to move forward and carry on working on access to healthcare and services to the populations that are suffering this year. The World Health Organization will be celebrating on the 10th of October the World Day of Mental Healthcare. And of course, there are many countries facing crises, and these crises will be increasing over time, as we can see, and therefore the question is how can we improve access to healthcare for these populations, and of course digital solutions could help us. However, they are not here to replace all other services, and they should not be considered as a magic solution. Step by Step is a solution that started in 2017 with the WHO in Lebanon. We started in developing an app. The goal initially was to help Syrian refugees and the Lebanese population. So in 2011, we had 1.5 Syrian refugees out of for a population of 6 million. So one person out of 4 was a refugee in
Donc,
Lebanon.
on a commencé
And
par
so we
élaborer cette intervention
started
qui est quand même basée
working
sur
on
une
this
histoire.
operation,
Donc, on
which is
choisit le
based on a
caractère.
history.
On avait 2 hommes
And
et
so
2 femmes.
there,
Donc,
there
le
was
bénéficiaire peut suivre
this story. We
l'histoire
had
d'un
two
caractère qui traverse
various
des
characters
temps difficiles, des
that
problèmes
are
de
facing
famille,
difficult situations,
etc.
family problems,
et qui cherche de l'aide et
access
qui
to
apprend
healthcare
à faire
problems,
des
and
exercices. Donc, c'est une
who
intervention qui est basée
is
sur l'évidence scientifique,
looking
sur
for help.
plutôt ce qu'on
And
appelle
so all this
le
is
behavioral
based
activation,
on
qui est une technique de
scientific
thérapie basée
evidence,
sur
and
sur
we
l'évidence
use
scientifique. Et à
various
travers ces caractères,
therapies.
on a
And through
dépeint
these
une histoire.
characters, we
Et donc, on a
came
5
up with a
séances.
story. So there
Une
are
fois qu'on
5
est
sessions,
enregistré dans
and
cette
once you are
application,
logged
personne
into
peut
this
suivre
app, the
l'histoire.
person can follow the
Elle
story.
peut, on lui
The
demande
person, so we ask,
son propre journal où elle peut
the
mettre ses
person has
exercices et
her
faire,
own
des
journal with
exercices, et
her own
elle a un
exercises,
soutien, ce
and
qu'on appelle à travers un
then
e-helper.
there will be
C'est-à-dire à travers
an
le chat,
e-helper
ou
providing
si elle
support,
souhaite, on peut
so
l'appeler
via
une fois par
chat,
semaine pendant 10 minutes
or
pour la
you
soutenir
can
dans ce
get a phone
processus.
call for 10 minutes
On a
once
fait
a
2
week.
essais randomisés
So we
contrôlés
carried out 2
sur
randomized
1250
trials
personnes et ça a prouvé être
with
efficace. C'était en
1,250 people, and it was quite
2018
efficient. This was in
qu'on a pu mener ça.
2018 that we
En
carried this
2020,
this
on a
trial.
fait une autre
In
recherche pour ce
2020,
qu'on appelle implementation
we made
research.
further
Donc, pour la
research.
mise en œuvre,
It
pour voir
was
comment
implementation
cette
research in order to see
solution va
how
s'intégrer
this
dans le
solution
système de soins.
could
Parce qu'une solution
be
digitale
integrated
qui
in
n'est
a
pas
healthcare solution, because a
intégrée dans un
digital
système
solution which is not
ne
integrated
sera pas
into a
durable.
system will not be
Ça va
long
partir dès
lasting.
que le
It
projet
won't
est
work.
fini.
It will disappear as
Et
soon as the project
maintenant,
ends,
avec,
comes to an end.
la,
And so
avec un soutien de la
thanks
Banque
to the
mondiale,
support of the
on est en
World
train de
Bank,
faire une autre
we
adaptation
are
pour la tranche d'âge 14-18.
working on
Donc,
adapting
on est en
this for
train
the 14 to 18
quand
years
même,
old. So we are broadening the scope
l'éventail des gens qui peuvent
of
bénéficier de
those who
cette
could
application.
benefit from this application.
Et on vient d'avoir aussi
And,
avec Welcome pour l'année prochaine
with Welcome,
des
We've
fonds
just
pour une recherche pour voir
received
comment
funds
on
for
peut
further research
vraiment,
in order to see how
augmenter
we
l'accès à cette
could
application. Parce que
increase
créer
access to this app,
l'offre,
because
c'est
to create an
important.
offer is important,
Actuellement,
of
on a
course, and
à peu
currently
près 6 000
we've
personnes
got
qui ont
some
bénéficié de cette
6,000
application
people
qui est
using the
pour
app
traiter la dépression
in
et
order to do something
l'anxiété,
about
comme
depression
vous
and
venez de
anxiety,
dire.
as you just said.
Mais
But
avoir une offre n'est pas suffisant.
to have an
parce
offer is
qu'il
not
faut
enough.
augmenter la
You
demande.
need to increase
demande, parfois, n'y
demand,
est pas.
and sometimes
Écosystème,
demand is not there because of
à
stigma,
cause du manque
because
d'informations
of
autour de la santé
lack of
mentale, les personnes
information
ne savent
around
pas que la
mental
souffrance
health.
est liée à
People
la
don't
santé
know
mentale.
that
Et,
sometimes they have problems related to mental health. So,
donc, avec cette recherche qu'on va
of
mettre en
course,
place, on
thanks
va
to
voir
this
comment
research that
en
we'll be setting
augmentant,
up, we'll
on va
see
augmenter
how
l'offre,
we can
mais aussi
increase
comment
the
on va
offer and
augmenter
how we can
la
also
demande.
increase yes, demand.
Que le
So
premier
you
retour
mentioned
soit
that the
efficace.
first feedback
Qu'est-ce que vous
was that
entendez
this
par
is
là? Quel est
efficient,
votre retour
effective. What do you
d'expérience
mean?
concrète
What is
que vous
your
pouvez mesurer aujourd'hui?
Alors,
what can
à
you
travers
measure
cette
in
application,
concrete
donc,
terms?
une
Well,
fois
through
que la
this app,
personne est enregistrée, il
once
faut
the person is
qu'elle
registered
complète
on the app, the
des
person must
échelles,
fill out a
des
certain
échelles
number of
validées, au début et à la
fields
fin de
and
l'intervention de ces
must
5
rate
séances.
the
Et après, on a eu
5 sessions.
des
And
analyses
so
statistiques qui ont montré
then
que donc, les
statistic
personnes
analysis
qui ont
showed
utilisé
that the people who
cette,
used this
cette appli, donc quand
this
on parle
app.
d'un essai randomisé
So
contrôlé,
when
ça
I
veut
say
dire
a
qu'il y a deux
controlled and
groupes,
randomized
groupe
trial,
qui
we have two
utilise
groups. One group
intervention, un
using
autre
this
groupe qui utilise autre chose,
operation,
en
and
fait,
another group
treatment as
using
usual,
something
une
else.
autre
You know, let's
intervention.
say treatment
Et
as
ce qu'on a
usual.
montré, c'est que
And
le
what
groupe
we
qui a
managed to
utilisé
prove
cette
was that the
intervention
group using
a
this
eu plus
system,
de résultats positifs pour
there
la
were more
dépression et
positive
l'anxiété.
results
Donc, plus de
with
gens ont bénéficié et leur
depression
score
or
sur la
anxiety, and
dépression
so
et
their
l'anxiété
scores
ont
on
diminué.
depression and anxiety
Et leur
went down,
fonctionnement a augmenté.
and their
C'est ce que j'entends par
functioning
positif.
increased. This is what I mean by positive impact.
Et donc,
And
effectivement, c'est une solution
so this is a solution which
qui améliore l'accès parce que
improves
les gens
access,
qui n'ont pas
because
envie de voir
those who
quelqu'un,
do not want
parler
to
avec
see
quelqu'un
someone,
pour
who
du
don't want
stigma,
to
ils peuvent
speak
aller
to
sur
someone because of
l'appli, ils
stigma,
peuvent
they
mettre,
can
même une adresse email qu'ils peuvent créer.
use this
on
app.
demande
They
pas
can
une
create
identification
an email
officielle.
address. There is no official
Aussi, ça met,
identification
beaucoup
required,
ça enlève beaucoup de
and
difficultés pour
it
l'accès
removes
géographique
a
parce que
lot
si
of
on est dans un
difficulties
petit coin
when
où
you
on n'a
are
pas accès aux
sometimes
soins,
in a remote
dans un pays où il
location
y a
with
des
no
tomates,
access to
on peut
healthcare.
avoir
In a
accès à
country
ces
with internet, you may have access to this type of apps,
gratuit au Liban.
Right now, this service is for free in Lebanon for everyone. There's a version in English and another version in Arabic. And the idea is to extend this to the younger populations, yes, for younger people, but for similar age brackets, we would like to reach out to more people, because in terms of access to healthcare, if we have 10 people with a depression, we know that there will be only 1 out of 10 that will have access to healthcare. This is worldwide. So the gap, what we call the treatment gap, this gap between people needing a service and those with a service is 90%. It's huge. And therefore, thanks to this type of solution, we can improve this situation. Thank you very much. We'll come back to you in a minute. We'll have many questions.
Vous êtes professeure adjointe clinicienne à l'université de Stanford et conseillère en chef en santé mentale pour Telehelp Ukraine. Vous proposez, alors les micros, le marron en français et les gris en anglais, c'est bon. Vous proposez du soutien télémédecine pour la santé mentale dans le contexte de guerre qu'on connaît en Ukraine. Vous collaborez avec des agences internationales pour former des professionnels de santé également. Et vous êtes par ailleurs experte dans la prise en charge des adolescents sur les questions de traumatisme et de prévention du suicide. Expliquez-nous comment vous arrivez à proposer ce service de télémédecine pour la santé mentale dans ce contexte particulier et effroyable de la guerre en Ukraine.
The English translation cut out right as you spoke.
Okay, do you want me to rephrase in English? Yes. Can you maybe provide, so you provide telemedicine support for mental health amid the war in Ukraine. How does it work?
Yes, excellent question. Sorry about the need for translation. So we're a completely volunteer-run organization started by a Stanford medical student and a Stanford engineering student that were personally impacted by the war in Ukraine and really noticed that there was a, as many places, a lack of services. And so we partnered with the Ministry of Health in Ukraine, as well as an online telehealth platform, Clinico, and recruited psychologists, primary care, specialty care to provide, online mental health care as well as physical care through this online platform. So we meet directly with individuals in Ukraine. We have translators that volunteer their time, or for those of us that speak languages. We have some patients that just come for one appointment, or some that I've been seeing now for 2-3 years. So really provides a lot of support. I think we've had over 4,000 mental health visits since the full-scale invasion of Ukraine began, and many more hundreds of primary care visits for individuals that simply cannot reach the clinic due to displacement, or the mental and physical health care providers there have now been evacuated or left themselves.
Is it easy?
No, no, especially Anushka and I were talking about in the training that we get in mental health care. It's very different. When I'm very used to telehealth therapy, I provide it in America all the time, but walking into a room, you really don't know what you're going to get. And it's been quite interesting to treat people from 6 to 80 and really consider what are the services on the ground that we can link people to, or if there are not any, to what level can we continue to safely hold them within a telehealth platform, considering things like, for example, if they're highly suicidal or have other conditions that cannot be managed. For the most part, we've been able to manage, I would say, the vast majority of mental health issues through our online platform, with the exception of maybe very, very active psychosis or active severe suicidality.
Which is the part of the population that is most concerned? Would you say it's children, adults, single women?
Yeah, I've actually been very surprised. Having done a lot of the stigma work and a lot of the research, I would have expected that we would be getting predominantly a younger population, and that's certainly true. We certainly have many 20 and 30-year-olds, but I've really seen a broad spectrum of, people signing up their parents, their grandparents, helping them figure out. So I would say I can't put an age on it. We get a broad range.
I don't know if I shall continue in English, maybe. So you provide direct care and collaborate with international agencies, as I said, to train health professionals as well in Ukraine. Can you also tell us a little bit about that?
Correct. We're sort of a two-faceted mission. On the one hand, we recognize that because of displacement, there is actually not enough direct providers in Ukraine to provide mental health treatments. So we come in as volunteers and fill that need. But we're also partnered for Safe Passage for Ukraine, which is an internal service that will take ambulances to Ukraine with an iPad and Starlink so that we can meet with patients in remote villages that wouldn't have access or be able to provide some evacuation as well. And we also partner with Doctors United for Ukraine and the Minerva Project out of Yale University, which really seeks to create a series of lectures to train professionals in Ukraine in a variety of evidence-based practices and treatments, and who have done a lot of work on the ground there to identify what are the actual needs of clinicians, what do they actually need training in as well. And then our staff is a really widespread. While many of us are from California, we have staff from all over the United States, as well as some Ukrainian psychiatrists and mental health providers that then we do internal training for.
Yeah, I was going to ask you, what do the professional in health need the most today?
The professionals in mental health, I think support would be great, funding, which I think is the name of what everyone is saying today. But I think when we speak to Ukrainian mental health professionals, it's access to ongoing evidence-based training and treatment. Yeah.
So I'm switching back to French. But just that one last question, Anaid, what are the main challenges you face? De quoi est-ce que vous avez besoin? Quels sont les défis?
So what are the main challenges you're facing today? Okay.
I think some of the biggest challenges we face, I think the speaker at the beginning spoke to very lovely, is that, we are very far into this conflict now. So continuing to have, interest, funding, time support, just getting enough providers to continue to donate their time is probably one of the biggest challenges we face. Is how do, most with an all-volunteer workforce, how do we continue to provide adequate care, quality of care? Can we scale? Can we do more training with who we have?
Lots of questions, beaucoup de questions. Merci Anaid. Lola Kola,
Thank you very much, Anaid. Lola Kola,
vous avez 15 ans d'expérience en Afrique de l'Ouest dans le développement et la mise en œuvre d'informations, d'interventions cliniques en santé mentale. Vous avez par ailleurs une solide expérience dans les camps de réfugiés au Nigeria sur la prise en charge de la santé mentale dans les camps, expérience directe dans un pays d'Afrique et expérience globale également. Je voudrais qu'on fasse un focus sur MHGAP, lancé par l'OMS. Il s'agit d'un programme
the OMS, which is a general program on mental health that you have implemented in Nigeria. Can you please, Lola, present this program to us? Of course I can.
Can you
go back
say
to
what
English?
You said in English?
Of course. Okay. Could you present? So the translation is not working.
Yeah, it wasn't working, so I just put it down.
Okay. I'll continue in English. Could you present the MHGAP program that you've launched in Nigeria?
Yeah, thank you very much. And thank you everyone for inviting me. And it's a pleasure to be in this lovely audience. So I had the privilege of coordinating the MHGAP implementation in Nigeria, funded by European Commission. And then I was a technical staff of the WHO working in Abuja. And and since then I've actually been part of several other global mental health initiatives. I've had the privilege of working with very bright minds in global mental health across low and middle income country settings. So MHGAP, just briefly, is a tool, a set of clinical algorithms from the WHO based on evidence that equips mental health, that allows the delivery of mental health care in non-clinical settings, in non-specialist settings, and sometimes in the community. So it equips non-specialist primary care providers in identifying and managing common mental, neurological, and substance use disorders, and it's step care. So it has some algorithm. Now in Nigeria, funded by EC, I led the implementation, like I said, and so I partnered. The partner was between WHO, the Federal Ministry of Health in Nigeria, specialists, the community, and then primary care clinicians, of course. So what we did was that we adapted the document, the guidelines, to fit the context, so that it's not just dumped on them. So we did that, and then because of limited funding, we were able to implement this in a state that had about 6 million population, and we were able to train several healthcare providers, hundreds, that went up later to train others. And but since then, actually, there's been other initiatives and that has based on WHO in Nigeria. And basically, when I coordinated the demonstration project, one of the things that we realized that people that had not had any access to treatment in their lives, I mean, sometimes some people that were even in their 60s, they had access through the primary care. So for me, from my experience, I see the WHO gap. I mean, it's a modality of care, right? But it's a platform for innovation, especially in digital health, because since then, a lot of innovations, including my own that I would love to talk about, but I will not take too much of Sophie's time. We've been able to adapt it, and like my colleague from Lebanon said, not to replace in-person care like that, not to replace other forms of care, but actually to supplement and augment it. Thank you.
Yeah, I was going to ask you, Lola, what is your lessons learned, maybe, retour d'expérience as of today?
Yeah, so one of the major lessons learned is that non-specialist primary care providers can deliver mental health care especially for common mental health disorders. They can identify and then they can refer, in primary care. So that is one of the things that we've learned. And then one of the other things we've actually learned again is that you actually can implement this without, a co-production process is always very good. You have to involve the community because there are a lot of issues at the communal level, either culturally or relating to stigma that actually could hinder care.
Thank you, Lola. Anushka Patel, do you have translation? Can I switch to French?
Can you hear the translation, Anushka? Okay,
great. Vous êtes psychologue
clinicienne spécialisée dans les traumatismes Massachusetts General Hospital of Boston.
On va faire un focus avec vous sur Empower, qui est une initiative cruciale dans le domaine de la santé mentale mondiale qui a été mise en place par le Mental Health for All Lab, le laboratoire pour la santé mentale pour tous, avec un credo, créer un monde où chacun a accès aux besoins de santé mentale dont il a besoin. À qui s'adresse ce programme Empower?
Thank you so much, Sophie. Am I audible? Everyone can hear me?
Yes,
okay, great.
Perfect.
Well, first of all, thank you so much for the invitation. It's such a pleasure and honor to be here. I'm learning a lot from the stellar group already, and I'm really excited to share some work about the Empower program. So let me kind of start by setting the stage, right? Like, what really is the kind of problem that we're trying to solve for as part of the Empower platform and project? Well, I'd like you to just consider that mood disorders like depression, anxiety, post-traumatic stress, and also suicide are the leading causes of the global burden of disease. They're also entirely preventable, right? And so when we kind of think about the fact that we have these diseases that are like pulling down humanity, causing so much stress, intergenerationally keep getting transmitted, but we also have treatments, well, what is the problem? Why aren't we sort of getting more treatments to more people? So, one answer is there's, of course, a complete over-reliance on expensive specialists, people like me and Anaid, licensed clinical psychologists, who took 7 years to get a PhD, several more years to do postdoctoral training. Well, why is this an issue? The issue is there will never, ever, ever, ever be enough, highly specialized psychiatrists and clinical psychologists to meet the treatment demands that we have as a global society, right? So 90% of folks need treatment and don't get it, as my colleague just shared. And so that's kind of where Empower comes in as a really innovative digital health solution. So broadly speaking, we need to kind of do three things in order to tackle this issue. We need to reduce the contributing factors like violence and poverty, and then we need to increase access to effective treatment, and we need to increase the number of providers who can deliver quality treatments at scale that are not necessarily psychologists and psychiatrists, which I'll go on to refer to as non-specialists going forward. So I'm going to focus now on how Empower does exactly that. So what is Empower? Well, Empower is essentially a digital platform created at Harvard Medical School. And the vision of Empower is to build the world's mental health workforce. The mission of Empower is to empower anyone, anywhere, to learn and eventually master the delivery of evidence-based psychological treatments. So how do we actually do this? Well, essentially, Empower is like a digital training ecosystem. You kind of log into it, you do a gatekeeping course called Foundational Helping Skills, which is about your bread and butter of what it means to be a good helper as a frontline provider. So this includes competencies like active listening, maintaining confidentiality, being respectful towards the person you're helping, and following the basic foundational helping skills, you can then kind of take advantage of a whole suite of digital tools to build capacity. So following foundational helping skills, for example, you can learn behavioral activation for depression, which is a CBT treatment. Or you might be able to learn, an evidence-based treatment to care for children with autism, which is a major neurodevelopmental condition that, especially in low and middle income countries, people have very little knowledge about. So the frontline workers who kind of take Empower courses are under training. And of course, the courses online are just step one, right? Just as in, kind of grad school, we take our courses, but then we also do case-based learning where we actually meet with patients. We have encounters with them. We have our supervisors, our mentors, our teachers give us feedback on it. It's the entire process is sort of built into this digital training tool, starting with courses on the Empower platform. Finally, examples of Empower initiatives include, as I mentioned, early interventions in schools for autism, early interventions for emotional problems in teenagers and adolescents. For adults, we're starting to work on acute stress disorder, which is, the kind of phenomena that emerges in early days after trauma exposure. And this is a project that I'm especially passionate about as a trauma-focused psychologist. But yeah, in a nutshell, that's Empower. We're trying to kind of scale the kind of work that people like Anaid are doing and scale it by creating an ecosystem where more and more people can learn more and more treatments and help more and more people in their own communities.
You might want to put back the headset for translation because I have a couple more questions following this presentation. Thank you. Est-ce qu'il y a des preuves?
Do you have proof that non-specialists can have really a good care that will be efficient against trauma? Do you have proof about this?
That's a really good question. So when Empower was built, I'm here representing Dr. Vikram Patel, who's my boss and like the genius behind the Empower vision. Vikram really is an expert in depression specifically. And so at this point, we have scores and scores of trials, randomized controlled trials, which is considered the gold standard of evidence, like in our field, showing that non-specialists can deliver depression care quite effectively in community settings, of course, under ongoing supervision, training, and with support structures in place. Now, I was very interested to know, well, is this really true of trauma as well, trauma and PTSD? Because I think PTSD, for example, post-traumatic stress disorder, is a lot more clinically complicated than something like depression is. And so I have been running this really big meta-analysis project, which is a study of studies over the last 4 years. And I now have 50 randomized controlled trials in my meta-analysis. And we're seeing that non-specialists all over the world in community settings, medical settings, refugee camps, writ large, a net effect that we're seeing is a moderately large effect size for reductions in PTSD. Now, it trails a little bit behind the evidence for depression and for anxiety, but I think that also reflects the clinically complex picture of what happens, with PTSD. And so it's really, really exciting findings, and we're submitting it actually to some journals for publication in 1 week. And so I would love to share the research with you all. But yeah, there's good evidence.
Anaid, do you agree with that from your experience? Vous êtes d'accord avec ce que nous expliquons?
Yes, I would certainly agree with that from my experience as well. It isn't really a matter of needing to have extreme specialists, but take the community partners that we already have, provide them the knowledge, provide them the supervision, provide them the support, the consultation on the ground to allow them to really connect with their communities and do the amazing work that they're even already doing even more effectively. And, you know, I think it's quite hubris of us to often think that we need that higher level of care, that we even know what's best in these communities rather than the people that are living in them every single day.
Rabih, vous êtes d'accord aussi avec ça, de votre vision?
Do you agree with this, Anaid?
Oui,
yes, absolutely. Anaid, there's the task sharing. That is to say that you don't give your task to someone who is not specialized. We're here to support them. You don't leave them like that, hanging free. So the aim is not to have specialists, but to change the role of a specialist, to have someone who supports and helps others, because we cannot do that. We cannot answer all needs.
Question in French.
Another question for you, Anushka. What is the last objective of Empower? What is your return on experience from this?
Could you explain what you mean by last objective? Do you mean like final goal or?
Oui, voilà, final goal.
Yeah, I mean final goal.
The final goal of Empower is to be a self-sustaining digital ecosystem that any kind of program, foundation, nonprofit organization, small little community NGO can sort of use this resource in order to train very, very much locally, like the people that are in the communities. And I really don't like this term non-specialist. It feels pejorative because everyone is a specialist in something, you know, as Anaid was saying, like the people that do this work on the ground, they do it beautifully. And it's because they're trusted leaders in their community. They're highly respected. They understand the ins and outs of the community way better than any of us specialists, experts, etc. can do. And so the idea is, how do we equip them with the right knowledge, skills, you know, the kind of capacity to be sustainable agents of change in their community, and how can we have a multiplier effect? So in some ways, I think of the eventual goal of Empower as a kind of pyramid. We start here, we start with training, and then we train the first cadre of workers. Those people become supervisors, they become leaders, they train more people, those people train more people. And so we end up having this really big pyramid where everyone has more awareness, everyone has lower stigma, everyone in the community knows at least a little bit of how to be more helpful and effective with just the people around them. So really trying to make local changes.
Merci beaucoup. Thank you very much. Let's open the floor to questions. On va passer à la séquence de questions. On va démarrer avec les questions dans la salle. On va vous apporter un micro. Merci de vous présenter en quelques mots et de formuler votre question de la façon la plus synthétique possible. Short questions and short answers. That way we'll have lots of questions and lots of answers. Alors, il y avait un bras qui se levait ici, s'il vous plaît, au quatrième rang.
Raised here on the fourth
Raise your hand,
rank.
sir. Yes.
This is the English mic, and we have a French mic, so if you can let us know.
English.
Thank you very much for your insights. My name is Shabs. I'm a family physician by background. I host a podcast on insights that all of us from contexts around the world can learn about good implementation. Thank you all so much for your insights. One of the things that came up a lot was evidence. We talked about treatment gaps, but there are also lots of evidence gaps, particularly in under-resourced settings. And I think, Lola, you had mentioned as well that often you've had to adapt guidelines that have been created in other contexts to fit the context. And so I see a world where actually the evidence that you guys are building up is actually helping so-called Western countries also help with healthcare deserts, rural digital divide problems. What can you say about that? What insights have you seen? Can you share any of your experiences on what you're building in terms of evidence?
Thank you.
Yeah, I mean, I can address that. So thank you for the question. So in terms of evidence particularly, I mean, we've said so much about the AMH gap now, and it's used in non-specialist setting, even though, I mean, I see Anushka saying that. I mean, we should use that in the proper context. So, so the thing about it is that image gap, I mean, the focus for image gap is actually equitable access and task sharing. So, and I don't think that that is specific to lower middle income countries where we have limited resources alone, because even in high income countries, there are several pockets, there are several settings where resources are low. So, you mean, this kind of evidence, we can always, I mean, it's what we could call north-south learning. You know, it's cross-continental, or, I mean, just learning from one other side of the world to the other. For instance, I mean, building evidence, I had the privilege of working with Vikram. He was the lead, I was the lead author, he was a senior author on a paper we published during the COVID, building evidence that what worked in lower middle income countries during COVID in the terms of using of digital technology to actually increase access, to support healthcare workforce, you know, can be done in high income countries too. So, I mean, so those are some of the ways that we've been building evidence of what can work in the different contexts, in the context of global mental health. Thank you.
Somebody else wants to react? Oui, Rabih, allez-y, je vous en
Maybe
prie.
just to add to that, I think what's lacking is implementation science. We know a lot about what works, so efficacy level data, I think there's a lot of good interventions that are working, but how does this intervention work in a specific context, and what does it take really to take an intervention from the stage where we know it works in a randomized controlled trial into real world settings? That's where we need more evidence, and that's, I think, is a big gap still.
Oui, Lola, je vous en prie. Yes.
Yeah, I just wanted to add a little bit more. Thank you for that. I mean, for bringing that out. You see, another thing that I think, another area that I think we need to really address, like you saying that, you know, what works in which context and for whom, you know, that is very, very important. And it's very important, again, to know, you know, there are a lot of evidence. I mean, in pockets in different countries. Like I said about image gap, over 100 countries have actually showed evidence that image gap can be used in non-specialist settings and things like that. But, you know, how do you bring all this together? So there's this data all over the place like that, evidence on that. And so what are we doing? Are we doing the same thing, rehearsing what others have done? You know, so there's need, again, for not only, okay, so for instance, we know that social support can help in depression treatment. I mean, just using that. So, but how does it work? I mean, what context does it work? Because you find that in some context, social support might help this person. In the other context, it might not help this person. This person might need medication. This person might need CBT training of just 6 weeks, 8 weeks, and somebody might need longer, and they are in the same country. So what are the mechanisms? I mean, it brings us to the field of how does it work? How does it work? Not just it is working, okay? But how does it work, and in which context? For who does it work? You know, those are things that I think are focus for evidence, yeah.
Thank you, Lola. Another question in the room. Yes, monsieur, on vous apporte un micro tout de suite. Mike is flying to you. English.
Sorry. Thank you. This is Jai from AHIN, Asia eHealth Information Network, and a partner of Foundation PFAP. My question is to both Anaid, Anushka, and Lola also mentioned some things related to that. Like, I've been in telemedicine for quite some time, especially in the crisis situation, like, for example, in COVID. A lot of these consultations actually happen on social media platforms. And then, like, but when a proper clinical consultation, we do expect to be done in a certain structured manner using electronic medical records and things like that, because clinical documentation is very important and vital part of teleconsultation. But how did you find the balance? Because there's always this question of balance between access to health at the same time the privacy, confidentiality, and security of sensitive health information. How did you find this? And then also, like, when you use variety of this platform, again, control or security of data, again, interoperability also becomes an issue. That's my question to you. Thank you.
Thank you, sir.
Yeah, I think that's such a powerful and wonderful question, and something I think about all the time. We were very lucky from very early on when we launched our platform. We launched with Clinico as our partners. So on top of being a telehealth online platform where they actually have video connection, it is an electronic medical record. So we have been able to, both fulfill our ethical duty, as well as in Ukraine, there is a legal responsibility to document every session. So we've been lucky to have that early on, because I know, otherwise we would probably be on, less secure methods like WhatsApp or Zoom or any of them. So I've been grateful to have a completely compliant medical record system, but I think it takes these innovative online platforms and ones that are willing to partner with NGOs, with nonprofits to provide us that care, as we're not going to be able to afford it all. I've also been thinking about it a lot. There's this real push for innovation interest, and I've been very mindful, being in Silicon Valley, there's a lot of interest to use our population for, AI interventions or things like that, especially because, as I mentioned, one of our biggest problems is finding the workforce. So while I can see the importance of needing to maybe limit some of our work by supporting, note writing or other things from our clinicians, how do we balance that with the privacy, especially with these marginalized populations? So it's just something I give a lot of thought to, but I don't know if anyone else on the panel wants to.
Do you want to talk about it? I can add something.
Mine is just a short answer, but the short answer is, at least through Empower, because we're not going direct to consumer, right? We're not dealing directly with patients that require treatment. We're dealing more with that middle layer of providers that will be giving usually in-person care to people. This is not an issue that we faced in the Empower realm, but I agree completely with all of Anaid's comments, and I think make friends. Like, you have to borrow heavily from other people doing innovations in those kinds of spaces, and it's really good to be connected and understand all parts that make the ecosystem run well.
And we had a question. On avait une autre question dans la salle, je crois. Oui. English mic.
Thank you. Thanks very much. Can you hear me?
Yes.
Okay. My name is Mary Kawanga. I'm from Wits University, Wits School of Public Health in Johannesburg, South Africa. I'm very excited to be here. I guess my question is mostly for Rabih, but I guess other colleagues, Lola especially, and others can also join in. I was very excited to hear you speak about implementation science, because I think that's, I'm always very excited to hear about new innovations for health. But what excites me even more is, sort of questions about how do we actually implement this innovation. And I think the difficulty sometimes with implementation is it's very context specific. And so what works, and Lola was speaking about this, I guess, what works in one setting may work, maybe the implementation challenges may come up when you try and translate it into another setting and so on. But I think in your talk, you mentioned that you've started an implementation study. And I was just wondering if you've got some insights, early insights from that, in terms of what are some of the key insights that you're learning about implementing e-health solutions like the app that you spoke about? And I guess the second question is about, what advice would you give? Because I think implementation science is less sexy, it's less exciting than coming up with a new app. I think funders are really looking for things like new applications and new digital solutions. But how do we excite funders about funding implementation science research? Because I think it's essential, because I think we've seen some of the innovations don't work, not because they're not efficacious, it's just because in the context when we're trying to implement them, they're just not being implemented well. So
thank you. So short answer if possible, because we have other questions waiting online. Thank you, Rabih.
Yeah, I hear you very well. Very well spoken from an implementer, I can see. So the step-by-step started in 2017. We did the implementation study in 2022. So it takes a lot of time to get there. There are very good frameworks for implementation research. We use the REAIM framework for Lebanon. And for example, some of the model in Lebanon, it is hosted with a local organization. Initially, we started it with volunteers, e-helper. Now they are paid because we found out after the economic crisis that we cannot run it just based on volunteers. And also we're integrating it in the packages of care at the primary care. So for example, instead of referring directly to a psychologist, now the social worker would help the beneficiary set up the app and start working on the app. So the question is, how do you integrate it within your own systems? And that's a question that is very context driven. We have the Lifeline, the 1564, which is also support people for emotional distress and suicide prevention. And one of the services they signpost is the app. So how can you really link whatever intervention you have into that? I think donors are changing their minds right now. There's more and more donors interested in implementation science. And as a matter of fact, step by step, got the UN Task Force for NCD and Mental Health Award for Digital Health in 2023. And that took us 7 years to get there. So I think donors are starting to change their minds about what works when they need impact. And it's definitely not just our cities.
We have a question here, a video question from Céphis and from Lomé. Une question de Céphis depuis Lomé qu'on va voir tout de suite en vidéo. Si on peut lancer la question. Voilà.
Chers panélistes,
Dear panelists, warm greetings. I am Sophie Noda. I'm a psychologist and clinician in Lomé, and I'm in charge of representing my campus. My question is, I would like to know, what is the clinical efficiency of these tools? How can they be assessed? And then, would there be any biases in the use of these tools? And if yes, what are the caveats for the professionals who would be using them?
Efficacité and bias. Who wants to give us a...
Yeah, I'm happy to start. So it's interesting because what we're dealing with is not a given psychological treatment. We're dealing with a different way of training. It really, in many ways, Empower is an implementation science innovation, because the idea is, the innovation is in the fact that we've created a system for training people at scale. But what we're doing for the training purposes, the treatments that we house on the Empower platform, all of that is not a new innovation. What we do is we kind of comb the literature, we make sure we're choosing and selecting treatments that already have lots of RCTs, lots of evidence behind them. But then the thing that we're testing as part of Empower is, does this actually work to train people at scale? Does it work well? And then what are the gaps and inefficiencies? So the kind of short answer is, we don't have all the answers yet, but right now we're doing a huge randomized control trial with 100 different clinics in Texas. So speaking to our podcaster's point about, taking lessons from the global south, bringing them into the north, this is so important because there are synergistic learnings that we can kind of have in this particular context, and we're in the middle of just gathering evidence for this at this point. So that's really where I'll pause, but we expect good results.
I'll give a very brief response. I think for us, it's really focused on patient-centered evaluation. So all of our patients complete questionnaires at the end of their visits. Finding well-researched, depression questionnaires that have actually been validated for the population we're working with in Ukraine, or anxiety or whatever it was a big challenge, just because they often don't exist. And so I think we're on the forefront of, through that patient-centered, look of what is their feedback. Do they feel like they're getting better? Back to an earlier question, we're hoping to use some of that data to help further other researchers to be able to give these interventions, or to see that the model actually works, or provide some data on the validity.
Thank you. Let's move on really quickly to the online question. The first one is for, la première question pour Anushka.
So the first question is for Anushka. How did the COVID crisis transform the perception of mental health on a global scale? Did you get the answer to the question?
That's a great question. So, in some ways, I think COVID was like the great equalizer. That's really how I think of it, right? So, I think everyone sort of intellectually knows mental health is important. Mental health and physical health are both important. But when COVID happened, all of us were stuck in the house. All of us were isolated. All of us felt lonely. And so when we were experiencing all of this collectively and together, not only the national conversation, but the international conversation became about the fact that, wow, this is having mental health impacts. Like, this is really hard on our psychological health and well-being. And if it's hard on us, well, gosh, it must be so hard for people that are, poorer than us, people that have, fewer resources, less family members, less social support structures. And so in some ways, of course, COVID was terrible for humanity, but in other ways, I think that it did spark empathy in a very widespread way. And it's kind of, it really was during COVID that the Empower platform and program was born. And I joined the Empower program with a simple email. I wrote to Vikram saying, I feel helpless. I feel sad. Like, the whole world is falling apart. I want to help. I want to do something. What are you working on? How can I be involved? So that's my answer about COVID.
Lola.
Yeah, I want to add this briefly. So I see you say COVID helped us to start reimagining global mental health, reimagining the delivery of services in global mental health, reimagining challenges. What are the challenges that we have in global mental health? Like I said, during COVID, I had a privilege of leading a position paper that was published in The Lancet that Vikram was the senior author there. So we had all this, we had some of the recommendations that we made. It had to do with the fact that, of course, we now saw that digital health and then delivery of psychological treatment, which most of the time is talk therapy, especially delivery of talk therapy, can be done digitally, okay? And then, because, we all know some of the things that happen. So it was expected, for instance, that in the global south, and I know it was bad in some places, but let me take in some countries in Africa. I remember when COVID hit, some of my friends in America, because when COVID hit, I was in Nigeria then, I was in the UK then, so some of my friends said, Lola, people are going to die on the streets. They'll be picking up people on the streets in West Africa. So, but you see, as it turned out, people the numbers were rising in the north. It wasn't so bad. It was bad. People died. It was bad. It wasn't that bad in the south. So, so why I said that is it helped us to imagine. So when we came together, I remember it was a project when we were writing the position paper. We started saying, what is working in the south that can be used in the north? What is working in the north? It's not that everything in the south was good. What is working in the south that can be, and that actually can be used in the south too. So there was some bi-directional learnings, which COVID provided us. Thank you.
Thank you, Lola. La dernière question, c'est une question de Kay.
Thank you very much. Last question from Kay Rapid TV for Mr. Rabih Chammay. How can we integrate mental health in primary health systems that are already made fragile by other priorities, such as malaria, VIH, maternity? Okay. Integrating mental health in a primary health system is not an event, it's a process. It takes a lot of time. We thought initially that all we need is to train healthcare professionals, and it was obvious. What we noticed is that we need a systematic approach, an approach by system. So we need human resources, we need medicine, and we need specialized human resources. And in Lebanon, after working for 10 years with the WHO in order to integrate mental health using the MHCAP, we reached this moment where we developed healthcare packages based on the MHCAP, because these are clinical guidelines, these are not healthcare packages. And so we split the roles within MHK for professionals, but at the same time we appointed one person, the social assistant, as the focal point for mental health. And every primary center had a specialized team with a psychiatrist and a psychologist working there part-time, with very clear references, with very clear algorithms. Now, on top of that, we integrated mental health into other healthcare packages. In other words, if someone has diabetes, he comes for his follow-up, and we are going to screen him for depression 3 times a year, and he will be screened also for other diseases. So we need to integrate integrate mental health in other healthcare packages. And to finish, in 2024, we made an investment case with the WHO. In other words, we calculated the cost of these healthcare packages. We saw the prevalence of the various disorders, depression and so on for Lebanon. We saw how much we need to pay in human resources, medicine, and we did the maths in order to see that if the government invested in mental health, it would save money because it would be improving mental health. And so we tried to get a law passed in Parliament in order to change the budget for mental health. Because it's fine to work, at local level with services, but we always need a systems approach when it comes to mental health. And so we need to work on laws or bills and research and of course with patients. And so it's important that we have a governance which can bring together all the players, produce a very clear strategy, use a certain number of interventions based on evidence-based approach, and a lot of patience, because we've been working on this for 11 years in Lebanon, and we're just starting to move along a little bit. Thank you very much. Thank you very much, the four of you, for sharing these insights with us, this experience feedback. Thank you very much.